Welcome back, everybody. Now we're going to discuss pediatric blood pressure. Blood pressure is very easy to understand. It's very easy to manipulate. As an adult, I'm probably 60 or 65% fluid. Infants are 80% fluid. So I think of blood pressure as fluid. Niagara Falls has a lot of fluid, a lot of pressure. My kitchen sink does not have a lot of fluid or a lot of pressure. Part of the problem with the sink is the faucet. The hole's too small. If I had a bigger hole, a larger gauge IV, I could automatically pump more fluid through it and get more pressure on this half. My goal is to get pressure over here. If I had a little creek and I put a ton of fluid into it, it would turn into a raging river with more power and pressure. And that's very similar to how you and I work. To me, a human is almost like a piece of fruit, like a watermelon. Like we look like a whole thing, where we're mostly fluid, or like a grape. You want to be a grape. You don't want to be a raisin. You want to be a grape. But infants and children have a higher percentage of volume than an adult. So infants and children get massive fluid boluses. Now, we're neonates for the first 28 days of our life. After that period, from that 1 month until our first birthday, we're infants. So if you have a neonate from 0 to 28 days with a systolic blood pressure, the top number in blood pressure less than 60, you're in a very late sign of shock, and that neonate is in a hypotensive level of shock. If you have an infant with a systolic blood pressure less than 70 millimeters of mercury, 70 millimeters of mercury is a magic number in PALS. If this infant has a systolic less than 70 millimeters of mercury, you're in a late sign of shock, and they're in a hypotensive, most likely hypovolemic level of shock. Now you go back to the 70 millimeters of mercury, and you take a child between the ages of 1 and 10. So you go 70 millimeters of mercury plus 2 times their age. So say I had a 3-year-old, and the 3-year-old, 70 plus 2 times 3 is 6, and a 3-year-old presents with a systolic of 68. This 3-year-old child's in a late sign of shock, a hypotensive level of shock, and you should expect to start giving them IV fluid. You're going to turn these patients into Niagara Falls, but just realize infants and children are designed to withstand. And they're built with many compensatory mechanisms, so we actually call it compensated shock. The goal is that you identify this child as being in shock, but they haven't yet given up their systolic blood pressure. So let's say I bring a child in who's 3 years of age, and we suspect they're in septic shock. If someone's septic, I'd expect them to be hot and febrile. Cold sepsis is so much worse. I'd expect them to be in sinus tach. Sinus bradycardia is so much worse with any pediatric patient. I'd expect them to be hot and febrile, red and flushed. I'd expect a shift in their bands. I'd expect a lot of things from them, and I would expect and hope that their systolic blood pressures are still stable. So when infants and children become very sick, you're going to see changes in their personality and their mental status first. When kids get sick, they'll be irritable and anxious. That makes perfectly good sense to be irritable and anxious when you don't feel well. That's like the first stage. When they get sicker, you're going to see children become sleepy, lethargic, drowsy, difficult to wake up, confused. You're already at the next bad stage. After that stage, they usually become unresponsive children. So you don't want sleepy, lethargic, confused, drowsy children. You don't want inconsolable children. All children should be able to be consoled, or they'll keep howling till someone finally goes, they're completely inconsolable. It must be something very important. So you don't want sleepy, lethargic children, and you don't want inconsolable children. So I bring in a 3-year-old, and their systolic is 74, but they're showing me all those signs and symptoms: sleepy, lethargic, elevated white blood cells, shift in their bands, they're febrile. I'm suspecting they're in septic shock. You're right, they are. They're in a compensated level of shock. They're compensating with their systolic blood pressures. I don't give it much more time, and that systolic blood pressure is going to catch up with the rest of this plan. When you give boluses of IV fluid to infants and children, these are massive fluid boluses. If you have a neonate or someone with a history of congestive heart failure, you're going to give 10 mLs per kilogram of isotonic crystalloid. Both LR, lactated ringers, and normal saline are isotonic crystalloid. So if you have a neonate from 0 to 28 days or someone with a history of CHF and their blood pressure is low, you're going to give 10 mLs per kilogram of either LR or normal saline. Once they're no longer neonates, past their 29th day, or they don't have a history of congestive heart failure, you're going to give 20 mLs per kilogram of isotonic crystalloid, normal saline or LR. These are massive fluid boluses. So if I hit a 30-kilo child, my first bolus would be 600 cc's. Bolus 2, I'm at 1200 cc's. Bolus 3, I'm at 1800 cc's of IV fluid. They would never let me give an adult a one-time bolus of 600 cc's. So just realize infants and children are designed to withstand. They're built with compensatory mechanisms, and one of their best is their systolic blood pressures. So if you have an infant or a child in front of you who's not acting like a normal child, they're sleepy, lethargic, confused, drowsy, difficult to wake up, and you're suspecting they're septic of any kind or in a form of shock, you could very well be right. And they may not have given up their systolic blood pressures yet. They're in a compensated level of shock. You want to get your hands on this situation right away. Once their systolic blood pressures fail, you're in a late sign of shock, and it's much more difficult to deal with. If septic shock hits the emergency room with a pediatric patient, they're going to give 60 mLs per kilogram of isotonic crystalloid. And when they get upstairs, they're going to give another 40 mLs of IV fluid. And it's still not enough. And still we have to pull out our drips. So when your patients have low blood pressure, just realize every form of shock, even cardiogenic shock, gets IV fluid. There are two types you're going to hang. You'll use LR or lactated ringers under limited circumstances. You use LR if your patient is pregnant, suffered severe burns, you work in the operating room, and now septic shock in the ER, as long as your kidneys can handle the potassium. If that is not the case, you're going to use 0.9 normal saline most likely. Just realize LR is a better formula. Lactated ringers has a similar pH to ours, 6.5, and has two critical electrolytes in it for our heart, potassium and calcium. So if I gave this person 3 boluses of LR, I wouldn't adjust the pH very much, and I, in essence, gave them potassium and calcium. Except we don't use a lot of LR. We use a lot of normal saline. When I use normal saline instead, there's no electrolytes, but normal saline is so acidic, I'll put them into metabolic acidosis. So the consequence of all the normal saline is metabolic acidosis. I might make this patient so acidotic I have to use sodium bicarb to reverse it. I actually don't care which IV fluid they pick. I love IV fluid and oxygen. Honestly, they're my 2 favorite things. And if you put this person into congestive heart failure, they'll most likely be intubated. Now, I'm not the one being intubated, but just realize that's not a big deal. And we're not going to trach and peg infants and children like we do adults. We're going to keep reintubating them over bougies and changing feeding tubes like Dubhoffs. But if someone needs that much IV fluid to support their blood pressure, they're probably going to need a few days off, and we'll intubate them and they'll just rest with us upstairs in the ICU. But supporting someone's blood pressure is critically important. And just realize infants and children aren't going to give this up until they're in a late sign of shock. They're in that compensated level of shock. And that's the last thing they're going to give up, and then that will fail as well. I hope this helps. Keep saving them. Thank you. Welcome back. I'm going to show you how easy it is to assess a pediatric patient. If you can, stop for a second and from a distance try to get a quick neuro and respiratory assessment, because when you go up to them, they're going to start crying, and there goes neuro and there goes respiratory. You want to see if they're making eye contact with their family, making eye contact with you, they're purposely moving, and what their breathing patterns are like. If they're struggling to breathe, you just want to get a quick assessment, neuro and respiratory, because when you go up, they very well could start crying. Now, if you have children at home, I bet they're healthy. At some point, you want to sneak in the room they're sleeping, and you're convinced you didn't make any sound, and they still wake up. That's a healthy kid. Healthy kids wake up spontaneously. It's 11 o'clock at night, and one of them standing in front of you. That's a healthy kid. Unhealthy children don't do that. When they get sick, they'll be irritable and anxious. That makes perfectly good sense to be irritable and anxious. After that, they'll become sleepy, lethargic, drowsy, confused. So you don't want sleepy, lethargic, drowsy, confused kids. You're already at that next stage. And after that, they'll be unresponsive. You also don't want inconsolable children. All children should be able to be consoled, or they'll keep howling until someone goes, they're completely inconsolable. Must be something very important. So if verbal stimuli didn't wake up a child using their first name, I'm basically going to yell in his name. To wake up a child, use their first name. They name the mannequin Kyle, so we just keep it up. So if this didn't wake up a pediatric patient, Kyle, wake up. Wake up now, Kyle. Wake up. Basically yelling in his ear, something is very wrong with this pediatric child. something is very wrong with this pediatric child not to wake up to verbal stimuli. We don't shake children because of shaken baby syndrome. That can happen until they're 5, so don't shake toddlers. What we do is we aggressively tap their foot. If this doesn't wake up a pediatric patient, something's critically wrong, and painful stimuli, we're going to pinch his big toe, he should withdraw. Now the difference is, if I found an adult who was unresponsive to pain, I'd be running away getting help. With infants and children, you're going to shout for help, but you're not going to go anywhere. You need 2 things in every medical emergency: more people and a defibrillator. So if you're dealing with the public, make eye contact with them, tell them what to do, and point at them. You call 911, bring me people. You go get an AED, bring me a defibrillator. In a clinical setting, you'd say, call a code, bring me people, bring me the code card. That's where the defibrillators are. You're going to shout for help with pediatrics, but you're not going to go anywhere. You're going to start this resuscitation. If 2 minutes from now the resuscitation's not successful or help doesn't come, then you would leave to activate EMS. But so many of their worst medical emergencies can be very quickly resolved, so you're going to start the resuscitation. So if he's unresponsive verbal, Kyle, tactile, painful, I'm going to shout for help. Call a code, bring me the code card. I'm immediately going to start the assessment. I'm going to check a pulse and breathing simultaneously in less than 10 seconds. If I can feel a pulse, his heart's beating, and if he's breathing, he's alive. I don't feel a pulse. I don't see any chest rise, he's not breathing. I'm going to start this resuscitation. Now, if I'm alone, it would be 30 to 2, 30 to 2. When there are 2 healthcare providers, it's 15 to 2, 15 to 2. 15 comes up all the time with infants and children. So if I'm alone with an infant or child, it's 30 to 2. And if you're there, 2 trained people, it's 15 to 2, 15 to 2. So just know, infants and children, this is very rare. Now, let's start. I'm just going to call this one PALS.
Oh, you can roll right into it.
The chance of you performing PALS level of care is less than 0.0025% of the general population of infants and children. It's very rare we ever have to do compressions on infants and children. Infants and children are born with very healthy hearts. If this child was born with a congenital cardiac anomaly, it's picked up the first month of their life when they're neonates. So if this was a little cardiac kid, we'd know about it right away, and they'll spend time at big hospitals like Children's in Boston. But infants and children don't really have cardiac problems, and if so, we know about it immediately. Infants and children have an airway breathing problem. A pediatric airway, his trachea that connects his mouth to his lungs, is the same exact size, width, or diameter as the inside of one of his nostrils, his nare, or the tip of his pinky. They have a tiny airway breathing situation. And to make things more complicated, from 0 to 6, their airway is shaped like a funnel. No one is going to have more respiratory problems than a 0 to 6-year-old. Every pediatric environment I've ever heard of made nursing responsible for suction. Imagine if I didn't set suction up, mucus alone can and does occlude this airway. But airway breathing problems are easy to fix, so that's a blessing. So statistically, you'll never perform, hopefully, CPR on an infant or a child. Well over 96% of infants and children that come to the emergency room go home. Infants and children aren't going to present to the ER with life-threatening situations like adults. Infants and children present with fixable stuff. Lots of respiratory situations, GI situations, dehydration, fevers. We fix them and send them home. Even with leukemia, the lowest they have in remission pretty much across the board with pediatric leukemia for remission is 96, 97%. Adults don't come out of these situations this way. Infants and children are designed to withstand. They're built with compensatory mechanisms. And I hope this helps you just have a quick assessment on an infant or child. Thank you. Have a great day.